To all.
Yeah, so I'll go ahead and start with roll call with the commissioners today. So good morning, everyone. It's Friday, October 18th. Going to take a roll call of the patient protection commissioners present today before we get started. So starting with Commissioner Jalen Behunin.
Present.
Thank you. And Commissioner Bio-Curry-Winchell.
Present.
Thank you. Commissioner Walter Davis.
Present.
Thank you. Commissioner Flo Khan.
Here.
And Commissioner Marilyn Kirkpatrick. All right, Commissioner Andrea Peterson.
Present.
Thank you. And then Commissioner Bethany Sexton did say that she would be unable to attend today. We'll mark her absent excused. Commissioner Wendy Simmons.
Present.
Thank you. And Chair Khan.
Present.
Thank you, Chair. We do have quorum. Before we move forward, just wanted to acknowledge the non-voting commission members that are present today, starting with the insurance commissioner. I believe Scott Kipper is unable to attend, but is Todd Rich, deputy commissioner, present today? Okay, hearing no one from the Division of Insurance. I believe we have representation from Department of Health and Human Services, Shannon Litz.
Here.
Thank you. And we'll mark you as attending on Director Whitley's behalf. Executive Officer Celestina Glover, are you present?
I'm here.
Thank you for joining. And Executive Director Russell Cook from the Silver State Health Insurance Exchange, I believe is unable to attend today, but I believe we have Janelle Davis.
Yes, good morning. I'm present.
Good morning. Thank you for joining. All right, Chair Khan, we do have quorum and can proceed.
Thank you very much, Joseph. For the next item on the agenda is the public comment. Ed, you want to give the preamble?
Yes, thank you. Joseph Filippi for the record again. So this portion of the agenda is for public comment. No action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on an agenda item for action. To provide public comment over the phone today, you may dial 775-321-6111, and when prompted, provide the meeting ID with the following number, 467-104-852#. Comments will be limited to 3 minutes per person. Persons making comments will be asked to begin by stating their name for the record, and please spell your last name. If you wish to provide public comment this morning and you're joining by phone, you can press *5 to raise your hand. If you're joining by computer today, please use the raised hand function at the top of the platform. And Chair Khan, it looks like we do have a hand raised. Valerie Kwape.
Please identify yourself. We have 3 minutes for the public comment.
Valerie, please go ahead.
Thank you so much. For the record, this is Valerie Kwape-Haskigan. Last name is spelled H-A-S-K-I-N. I am the Rural Regional Behavioral Health Coordinator, and after perusing the updated work session document, I just wanted to make a note that anytime that there is funding or resources allocated towards the AHEX, that has been very successful for rural Nevada. Additionally, with the Rural Regional Behavioral Health Policy Board's bill last session, AB 37, which created Be Here Nevada, we were able to get that through by using existing resources such as those provided by the AHEX, which really already have a pulse on engaging with K-12 and the universities, et cetera. So their work heavily influences a lot of other items that were on the work session document. So anytime you have the opportunity to look at advocating for funds or resources for them, that is likely a very positive thing for rural Nevada. Thank you.
Thank you very much.
Yep, thank you, Valerie. Dr. Khan, we have one more hand raise. Natalie,
Sure.
Please go ahead and state your name for the record.
Good morning. This is Natalie Powell for the record, N-A-T-A-L-I-E-P-O-W-E-L-L. I'm the director of the Nevada Certification Board, established in 2016. NCB is an affiliate member of the International Certification and Reciprocity Consortium. ICNRC for short. We provide peer and prevention certifications through ICNRC. In 2019, we were approached by the Division of Public and Behavioral Health in Nevada to begin certifying community health workers. We also recently began certifying birth doulas in collaboration with Nevada Medicaid. So that's our background. But since 2020, we've been really, truly privileged to collaborate with High Sierra AHEC in providing Nevada cultural competence training to all of our certifications. For all of our certifications, as well as other AHEC educational opportunities that serve to both address and reduce health disparities in Nevada for Nevadans. NCB continues to collaborate with a variety of activities with AHEC, not only improving health access and promoting health equity for all Nevadans, but also addressing, and I think this is critical, underrepresentation among healthcare workforce at every level, especially given, our well-documented healthcare shortages, our HIPSAs, but perhaps most exciting of all has been the opportunity to collaborate with High Sierra AHEC to develop culturally relevant high school community health worker certification, and we started working with them on that in 2021. I think hundreds of students have gone through that program, and it would be a shame to lose that, and it would be a benefit to all of Nevada to be able to expand that. AHEC's High School CHW program provides pathways to healthcare careers for underrepresented populations, as well as providing CHWs, community health workers, who are truly representative of their communities, which is also very important, particularly in our rural and frontier areas, but really everywhere we are in Nevada. As director of NCB, I also appreciate that AHEC is constantly proactively reaching out to me to seek to improve their curriculum and programming. And I just think I can't say how much I value them as a stakeholder and a collaborator. And I just feel very strongly that level. So thank you.
Thank you, Natalie.
Thank you
Appreciate your
very
time.
much. Yeah. So anybody else, Joseph?
Anyone else wishing to provide public comment, please press *5 if joining by phone, or raise your hand through the Teams platform. Dr. Khan, I'm not seeing any additional requests for public comment.
All right. Thank you, Joseph. Moving along with our agenda item number 3, this is for possible action. It's review and approve meeting minutes from September 20th, 2024. I believe everybody did receive copies of the minutes. If no questions or changes recommended, I would ask for a motion to approve.
Chair, this is Wendy Simmons. For the record, I move approval.
Is there a second?
Marilyn Kirkpatrick as a second.
Thank you. Any opposed to the motion? If none, the motion carries. Item number 4, update on the establishment of the Student Loan Repayment for Providers of Healthcare in Underserved Communities Program, created by Assembly Bill 45(2023) and codified in NRS 226.458. We have 20 minutes allocated for this. Joseph, do we have Eric Jimenez here to talk about it?
Yes, this is Joseph Filippi for the record. I believe we have Eric Jimenez, who's the Chief Policy Deputy at the Nevada State Treasurer's Office. Eric, whenever you're ready, feel free to pull up your slides and get started.
Awesome. Thank you so much, Chair and Director. My name is Eric Jimenez. Thank you so much for giving us the time today. I'm sure many of you have heard about this program, but we are finally ready, I think, as we reach the new year to implement it, and it's very exciting. And I think we'll more than triple the existing loan repayment we have for providers of healthcare. In statute, this is called the Nevada Student Loan Repayment Program for Providers of Healthcare in Underserved Communities. We will be changing that name to something much shorter, but we are very excited about this program. As the director mentioned and the chair mentioned, this was made possible through the passage of Assembly Bill 45, which we're very excited passed unanimously in both houses. This program has dedicated funding, not just for itself, but also for the Nevada Health Service Corps program, so the existing student loan repayment program out of the University of Nevada School of Medicine gets its dedicated federal match for this program. And this is very important, and I'll touch on it because we wanted to make sure if we were asking providers to commit to practice in some of the toughest communities, we felt it was very important to have dedicated funding for it. So this program receives $2.5 million each year as an automatic statutory trigger out of the abandoned property trust account, which is unclaimed property. And essentially that happens at the end of each fiscal year. So we don't have to go to the legislature ever to receive this amount of funding. Now, there could be conversations whether that funding would need to be adjusted, but this transfer happens automatically. Providers who choose to apply or is successfully approved for the program can receive up to $120,000 in exchange for practicing in an underserved community within the state. There was a robust discussion during the legislative process. We kind of initially modeled the definition after the existing providers of healthcare definition in statute, and the legislature made some choices to kind of whittle that down and focus. But this program is so far the most comprehensive program for a student loan repayment program of its type for a wide variety of providers. And you can see this on the screen, but we wanted to be, I think, holistic as much as we could, recognizing we couldn't get to everyone, but recognizing that communities have different needs, and we wanted to be able to finance a variety of provider types. This program is meant to be flexible, and we could talk about how certain types of applicants will be scored through the process, but there are three statutory requirements for eligibility in this program. One, you have to be a current Nevada resident who is actively licensed in good standing. Two, you need to be committed or engaging in practice in an underserved community, and we can talk about what that means. But this is, I think, a really key point is the goal of this program, I think, is twofold. One, to attract new providers who might be practicing somewhere else or in Summerlin or in South Reno to maybe practicing in a more at-risk community, but also to retain some of the folks who might be practicing in places like Elko and things like that. And then you must also commit to clinical practice for a period of 5 years. And we felt that was very important so the state gets its best bang for the buck on it. On clinical practice, like I said, this requires an applicant to commit to 5 years of practice. They are allowed to change locations as long as they move to another designated underserved community, and providers may be able to practice at multiple locations. We know that some providers work within multiple institutions in a hospital system or an FQHC system. So we wanted to recognize that and have some flexibility within the program. The underserved communities are prescriptive by statute. We try to be broad in these interpretations, but also we recognize that if you don't fall within one of these communities, there's really nothing we can do. So someone would have to check at least one of the boxes for these to be eligible for the program. Some of these you might check multiple boxes, and that's great. Be qualified low-income census tracts as determined by the Department of Housing and Urban Development, a census tract that scores high on the CDC's Social Vulnerability Index, in a community or largely a community defined by the last census with over 20% of households that are non-English proficient, tribal communities, both colonies and reservations, anywhere in a rural county with less than 100,000 people. So that would be every county other than Washoe and Clark. And then this is something we're kind of working through using data and economic data on. But in communities that have been historically subjected to redlining, segregation, and other discriminatory practices. So if let's say you're a provider, you're practicing at multiple locations, if you are at least practicing in one of these locations, you could be eligible for the program. We do have a scoring mechanism that I'll talk about, but obviously, if you're spending 100% of your time in an underserved community, you would be scored higher than someone that was practicing 20% of their time in an underserved community. We went through a robust, not only legislative process, but a robust regulatory process as well. And if anyone is from the commission is interested, I'm more than happy to send you those regulations which have been promulgated and passed by the Legislative Commission. That outlines kind of what the application process looks like. We expect this program to go live in January. There's just kind of some moving parts like launching an application portal and doing a rebrand and things like that. But we are expected for this program to go live early next year. Pursuant to the adopted regulations, we are required to post 3 documents 30 days prior to the launch of the application, which we will make sure to share with this group. The first of which is pretty load bearing. It's the total amount of repayment that will be available to providers in this cohort. So we're structuring these as kind of application cohorts. There will be an early 2025 cohort. People will be able to apply for a period of 30 days, and then that application window will close. We will evaluate applications and then make awards. Since this is a 5-year commitment, we are technically, we are assuming that we have a 500% obligation for the funds that we approve in year 1. So what that means is we won't necessarily issue all of the $2.5 billion that we have available because that would put us in a fiscal cliff within a couple of years. We expect in year 1 to offer about $1 million in loan repayment to providers. Those dollars will be tranched. And I know we've had some robust discussion with provider communities, but we intend to give basically 20% of the eligible repayment for a certain provider type in year 1, and then kind of move down the process. So if someone falls out in year 3, the state isn't out of money for services that weren't provided. The second document that we have to produce 30 days before the launch of the application, which will be in December, is the scoring rubric. The scoring rubric is outlined in the regulation, but it does a number of different things. And those were largely the conversations we had with many of the folks that are on this call today. We are required to disperse the first 15% of dollars available within each cohort to providers that meet the qualifications that are in rural communities. So they will obviously be kind of scored highest first and move down the process. From there, we are prioritizing 2 types of specific provider types. One is those who are providing primary care and sexual and reproductive healthcare services, just kind of dealing with the influx of patient load that we have after the Dobbs decision. And the second provider type that will be prioritized will be those who are providing behavioral healthcare services within one of the communities that are outlined in this bill. That does not mean that other providers who aren't providing these services can't go through this process. It just means they won't be scored as high as other folks that will. There are a number of other metrics that we'll be using during the scoring rubric that will kind of, I think, pick the providers that we think are doing the right things. One is kind of a commitment to serving Medicaid, CHIP, and Medicare patients. So applicants will be scored based on their, 1, willingness to do that, and 2, their existing patient load if they have it. So we'll be working with Medicaid and other folks to determine in human resource providers to make sure that individuals who are serving 100% of Medicaid patients would be scored higher than someone that was scoring 15 Medicaid patients. Additionally, we have other metrics that will score different providers accordingly. One is if you are the only provider within a 50-mile radius of a particular provider type, you would be scored higher. And I think that's pretty self-explanatory that if you're the only optometrist in Battle Mountain, the state should be trying to do what it can to make sure you have access to this program. And then finally, the last document that will be posted is the application itself, so that applicants will at least have 30 days before the launch of the application to gather the necessary documents before the application goes live. So what happens after a provider submits? They'll receive an automated letter that we have the application, it's under review. After that process, we will work to make sure that we have all the necessary documentation. Thanks to so much of the good work of our licensing boards, much of that information is available internally through the state, and we're hopeful that the application will be robust enough to get the information that we need, but easy enough that a provider could complete it within a 20 or 30-minute period. And then if an applicant is successful or not successful, they would be notified of their award. If an applicant wasn't successful in the 2025 cohort, they could always apply in the 2026 cohort. And I think that's why it's very important that we have dedicated funding for this program. And then I think this is important as we talk to different providers, but funds will be dispersed over a 5-year period. And that is purely a risk mitigation technique from the state to ensure that applicants are doing the 5 years of service. They will go directly to the servicer of a provider student education loan. So again, a state protection. We did this a lot with some of the COVID money that went out, both for renters and landlords and things like that. By making the payment directly to the person that's owed the money, it limits the opportunity for those dollars to be used in a way that is not necessarily the intended purpose. And then payments will be made in arrears. So therefore, if a provider gets approved for this program, that payment will be made at the end of the year of that service. Again, a risk mitigation technique, but also to help us from an administrative perspective, not have to try to front load a bunch of payments in January of this year. And they'll be paid annually over a 5-year period. And we can talk about the amounts in a minute. And then we are working to get a confirmation from the Internal Revenue Service on this. But there was a provision within the Affordable Care Act that state-based student loan repayment programs for healthcare providers in underserved communities have an existing exemption from federal income tax calculations. Like I said, there is one on the books from the federal government. We are just clarifying with the IRS that that this program would be exempt from federal income tax, but we would make sure that applicants know either way beforehand. I think I had a repayment amount slide, but I don't know what happened. Might be gone. I think that's it. If there's any questions, I would be happy to take them.
Thank you, Eric. Appreciate your presentation this morning. And I personally just was excited about that bill in following it last session. And so glad to see that there's momentum and that the implementation is on its way. If any commissioners have any questions for Mr. Jimenez while he's here, I see a couple hands raised. Walter Davis, please go ahead.
Yeah, hi. Thank you for the presentation. One question I have is, are there any risks for a provider that does not complete their 5-year commitment for repaying the loan or to the organization itself?
Absolutely. Great question, Commissioner Davis. We have been grappling with that, and I think we have a couple of different mechanics. One, the way that we're dispersing the money, I think, limits state exposure, right? And also make sure that there are dollars available for other providers if someone leaves. If someone is approved for the program prior to us sending out funds, they will be required to sign basically a student loan repayment agreement that we're getting vetted through attorneys right now. That agreement has some teeth. So if that provider just up and quits and kind of walks away, there is a series of corrective actions that could be taken by the state to recoup any of those dollars, or if there was any sort of fraud on the application or things like that. With that being said, I think it's incredibly important that the state have some degree of flexibility here, because sometimes providers have to leave through no fault of their own and have family situations or medical emergencies or things like that. So we will have a provision for kind of like an undue hardship. There's probably a better way to phrase that, where if a provider completes 2 years of service, and they can demonstrate that the factors are outside of their control, we would allow them to leave, thank them for their 2 years of service. They just wouldn't get the outstanding 3. So that's kind of why the funds are being structured and tranched in the way that they are. I hope that answers your question.
Yes, it does. And if they are found to not be a good fit for the organization that they signed up for, is that what happens in that case?
Yeah, so this is something we're also grappling right now. So if a provider's approved, let's say they're working in a hospital system, hospital in Elko, they are terminated for some reason. One of the provisions that we have in our loan agreement that is that if you are, if from a licensing board perspective, if there is a negative action taken against you for doing something like that, that is grounds for termination in the program. If for some reason there is either some sort of disagreement or whatever happens on the termination of someone, we do allow for you to move if you secured employment within a certain number of days. But I think it would largely depend on what the circumstances are within that termination. If it's just not a good fit, then that provider could move to another designated location. If it was something more serious, that could be grounds for termination in the program.
Thank you. And just one more question. Is there any requirement for the employer of that individual to give notice to the organization prior to termination? Is there any conversation that needs to happen prior to?
It's a really good question. I think right now the way we're contemplating this, and I'm not saying that this has to be the way. I'm open to feedback on this. Is that most of the onus is on the provider themselves, since they're receiving the repayment, right? Like it's on behalf of them. So if there was a change in employment status or something like that, they would have to notify. I will say that the employer will play a role here in 2 places, and I'm willing to think about other places they can play a role if necessary. The first is kind of a verification form. So say a provider goes to the program, gets kind of pre-approved or before we make our final determination, they will have to submit kind of an employment verification form with their employer, largely the human resources department, or I know some providers are small shops, so whoever handles that, that goes through how many hours is this provider working, which locations are they working, what kind of Medicaid patient load are they seeing, and other pretty obtainable factors. And then that form will need to be filed again on an annual basis. So we're really hopeful to take an annual look at this. So if a provider was seeing a bunch of Medicaid patients in year 1 and then dropped off, really what kind of the question is like, why? But I think at that point, that would be the only onus on the employer, unless there was a really good reason that we needed to keep following up with them.
Thank you.
Thank you very much. Any comments, questions?
Flo Khan, please go ahead.
Yes, thank you. Just a couple questions around after the student has completed the program and their payment has been made, are you doing any measurement to see whether or not they stay in the community that they are in after they've completed the program? And if not, why? Why they might have left, to just better understand going into the program how you could retain those folks in those areas. And again, just reasons maybe of like just keeping them there. That would be one. The second is around hardship. Obviously, limitation of funds limits how much you can actually repay in the program, but is on the front end, is that still prohibiting underserved, individuals or people from communities of color from actually even entering into the program to begin with, given the limitations on how much they can actually get repaid, their student debt can be repaid.
I am going to take the first one first, and then we can have a much more difficult structural conversation on the second one. On the first one, the program hasn't launched, so we haven't collected any data yet, but that does not mean that we won't be collecting data. So that's, I think it's a really good point, and I even took some notes on it, of the data that we're going to collect kind of during the process and after the process. One, I think that's very, very important just to make sure that we're sending money to the right people and they are doing the things that they're saying they are. But also, I think we can learn a lot of valuable things. Although this will be kind of smaller scale, it'll still be the largest program that we have for this type of program. And I think it will be useful for groups like this, right? On if providers are leaving for a particular reason, or if we find out that the loan repayment is not enough, or like whatever types of factors there are, I think that would be interesting. So I put, kind of an exit survey on my my list here, but I think either kind of regular surveys or an exit survey as a requirement would be a really good use of time for us, and we'd be happy to share that data as we go. On the second question, yes, I recognize your concerns. They are valid concerns. I think there are some structural barriers that get the types of providers we want to see in the communities we want to see them in. We had a lot of conversation around, should we do a large lump sum payment as opposed to kind of spreading it out over time. And it ended up being, just from a state perspective, we expect to run out of money for this program. So we wanted to preserve those funds. We have a model that basically funds this program in perpetuity. So we kind of went through fiscal solvency and had to make a trade-off there. I recognize that certain types we want to make sure that underserved provider types are within certain types of communities. And so we have done some things in the scoring metrics that I think are helpful. One is a language proficiency question. So let's say you are practicing in a largely Vietnamese community and you speak Vietnamese, and would be serving that type of patient mix. You would be scored higher within that program. And I think we're also kind of wrestling with one of the eligibility criteria on providers who are practicing in those historically underserved, redlining, and kind of segregated communities. I think we have so much more work to do on that. But I think after we get some data for the first year of the program, we can shift. One of the things we did in the regulation, and I'm sorry for such a long answer to your question, is we built the ability to move some of these metrics. So one, the total amount of repayment, the scoring rubric can be changed on an annual basis. So if we really, let's say the state realizes we are not serving the AAPI community in this location, we can score for that, right? Or if we become in a social worker crisis, we can score for that, and we can kind of move a little more rapidly than having to go through a legislative change.
No, thank you. I think that's a great answer, and it sounded like when you were talking about the scoring rubric that you have taken a lot of the factors into consideration to try to drive to try to secure applicants of a much more diverse background. So thank you.
You're muted, Dr. Khan.
Anyone else had any questions? Because I will have one after they've completed the round with the rest of the commissions.
Not seeing any hands raised. Feel free to go ahead.
Okay, thanks. So a little bit of historical perspective on this. In the 80s and early 90s, UNR had a program for the medical students to go and do an attachment/internship for a period of time in the so-called rural areas. The reason I'm aware of it, in the early 80s, I used to live in Boulder City, and that was classified as a quote-unquote rural suburban area at that time. So I got 2 students assigned to follow me and for a 3-month period. The idea was to incentivize the students, to realize what it is like, although Boulder City was not quite as rural at that time. Having said that, that program didn't work. Also, the students who originally were from, say, Winnemucca, some of those rural other areas, would go through the medical school with the understanding they'll go back, but they all left their residence areas in the rural Nevada and worked in Vegas or Reno, etc. So the incentives are a challenge, but what is the disincentive for those who do come in under this program to not leave? I know the military, the armed forces have a period to serve 12 years or something.
Yeah, I think those are all really great points and something we're walking into this eyes wide open, which is why we've kind of expanded geographic location and both provider type eligibility for this program. I think the disincentive, we recognize we only have so many tools as a state. So the first thing is kind of that commitment for 5 years of service. And then it's that the teeth that are in the loan agreement. So we're still going back and forth with legal, but I have it that written today that if someone left for, let's just call it not for a good cause, right, an undue hardship cause, they would have to pay the total amount of repayment back. And when we say the total amount, it would be the full $120,000. So if you only received $90,000 into the program and then you left, you could be on the hook for $120,000. So it's kind of the balance. Like we do want to provide, kind of a disincentive for folks to participate in the program, but we also recognize, just with the healthcare shortages that we see across provider types, that we have to be flexible, I think, in this. And I don't know if there's a good answer, and I think we'll probably learn a lot more as we go through this first cohort.
All right, thank you. Any other questions? No, if not, then thank you very much for your presentation. We'll move on to the next item on the agenda, item number 4, which is update on the establishment. Oh, we did this, I think, didn't we?
Yep, we're on item number 5, Dr. Khan.
Item number 5 is the work session discussion and possible action on recommendations to address the healthcare workforce shortage in the state of Nevada. We have allocated 40 to 60 minutes for this. Joseph, you want to take it on?
I'd be happy to, Dr. Khan. Thank you. Joseph Filippi for the record. So today we're going to conduct our work session, commissioners. Prior to today's meeting, each of you received the list of recommendations for discussion today. So I'm just going to read a quick note before we get started. So in coordination with the chair, commission staff of the PPC have prepared a work session document to assist you all in determining recommendations you may want to include in the next statutorily required report. The work session document contains a summary of recommendations presented during commission meetings, received through communication with individual commissioners, or through correspondence submitted to commission members or staff. The members of the commission do not necessarily support or oppose any of these recommendations. Within the document, commission staff compiled and organized the proposals so that commissioners may review them and decide whether or not to accept, reject, modify, or take no action on the recommendations. The work session document groups the proposals by topic, and they are not preferentially ordered. It should also be noted that any potential recommendations that include a fiscal impact has not been determined at this time. After consulting with the chair, the items concerning the letter of support for the pharmacy BDRs and the recommendation to provide physician assistants with broader practice authority will be withdrawn from the work session for consideration at this time. It's been determined that the Nevada legislature would be the best forum for these conversations to occur. The commission will continue to monitor those proposals and any additional pieces of legislation related to that in the upcoming session. So the revised document that was distributed publicly yesterday includes 23 recommendations and 5 letters of support for the PPC to consider today. A survey was distributed to each of the commission members prior to today's meeting to gather initial feedback, and those results are also included in each of the upcoming slides. So moving right along to the first recommendation, I'm going to quickly just read the recommendation and then open it up for discussion and a vote from members. Recommendation number 1 would request the state of Nevada to identify ways to recruit and retain a more diverse healthcare workforce. Increasing the diversity of the workforce will in turn increase the number of providers practicing in the state. And the PPC discussed how lack of diversity may deter prospective medical graduates from completing their graduate medical education in Nevada. Additionally, in reviewing a study recently published by JAMA, according to that study, additional efforts are needed to increase the representation of Black, Hispanic, and Native American people in healthcare professions, and measuring and reporting on the representation of minority groups in the healthcare workforce and in the educational pipeline may encourage these efforts. According to the survey that was distributed to members, there was unanimous support for this item. And I'll now open it up for commissioners to discuss this recommendation further if needed and vote.
I think if we have had unanimous support for this, unless somebody has a compelling additional comment, we can proceed to the vote.
Mr. Chair, for the record, Wendy Simmons, I move that we approve recommendation number 1.
Thank you. Any second?
So I just have a question. This is Chairman or Commissioner Khan. I just have a question. So there's 32 recommendations, correct, Joseph?
23.
23. Sorry, 23. I was close. I just flipped the numbers. We are only going to be able to move forward, though. Is this part of the BDRs that we're looking at doing?
Sorry, and thank you for the question, Joseph Philippi, for the record. So for clarification, these are not for BDRs. The commission has voted on the 3 BDRs that we're allowed to submit to the legislative session. So these recommendations would, if approved, be included in our report due to the governor and the legislature in January. The commission's responsible for providing recommendations every 6 months to address issues related to healthcare access, quality, and affordability. And additionally, through the executive order from the governor's office, we've been asked to provide recommendations to address the healthcare workforce shortages. So these would just be in addition to our BDRs, additional recommendations that the commission is considering that would move the needle and address some of these healthcare workforce challenges.
Okay, thank you. That's helpful.
So can we move along for this one? It's approved. Was anybody opposed?
I think we had a second from Commissioner Simmons. Are there any opposed?
Joseph, I would suggest please do identify the recommendations that the commissioners have by consensus supported, so we can, in the interest of time, move along unless there are new questions on those, since everybody has had a chance to review them.
Sure, Commissioner. So there wasn't really many that were opposed. And so what I was planning to do is to go, for transparency purposes, one by one, just read out the recommendation, give you all an opportunity to discuss it, and then move forward with approval.
Yeah, that's fine, Joseph.
Okay.
Joseph, can I ask a question though? It's Marilyn. Can I ask a question though? Does it not make sense? So sometimes at the county commission, we read them all into the record, and then we ask who may have questions on certain ones, and then you could do a broader motion. I'm just curious if that's an option. I could just see us being here at 5 minutes times 23.
Yeah. Understood, Commissioner.
It's a good suggestion, Commissioner Marilyn. So, Joseph, how would we like to proceed?
So yeah, taking that feedback, I will go ahead and just read each recommendation, ask if there are any questions. If no questions, then I'll go ahead and move forward, and the commission can take a vote at the end to approve the recommendations as presented or modify as needed. Does that work for everyone?
Joseph, I'm just slightly concerned. I want to make sure that, while I like the idea of moving forward quickly, I also want to make sure that all of you have the opportunity to stop at each moment and really have any discussion that you'd like on any of them and take a vote separately on any of them. So perhaps we can do it. I think if we just move forward quickly on this, we probably could just move through each of these in just less than a minute with a vote and separate on each of them. But if we want to do it together, I think we can do that. But let's still move through them slide by slide and just indicate if it's consensus. And if for anyone for all of them are consensus, Joseph, if you can keep track, we'll have one vote for all of those at the end. And then anything else, let's deal with separately.
Thank you. Thank you, Gabe. I appreciate that. So taking that feedback, I think there was a consensus on this first recommendation. We'll move on to the next. So recommendation 2 would request the state of Nevada continue to develop workforce incentives focused towards recruiting occupations in undersupply and target rural and underserved communities to improve access to care. Offering financial incentives to providers such as stipends, loan repayment options, and higher reimbursement rates have proven effective and also could be enhanced. According to the survey, there was unanimous support on this item. Are there any discussion or questions at this time? Hearing none. Moving on. Recommendation number 3 would recommend the state of Nevada identify ways to reduce or cap the amount of interest issued by insurers on medical education loans. High cost and interest rates on education loans can be a barrier to attracting and retaining providers, especially in rural and underserved areas. Just briefly wanted to say, according to the American Medical Association, the enormous debt load medical students face is further compounded during low-paying residency and fellowship training. Even if a graduate qualifies to have their payments suspended during their training, their loans continue to accrue interest, which increases the overall debt. So this recommendation would seek to identify ways to incentivize providers to practice in Nevada through loan interest deferment and/or loan repayment options. According to the survey, there was 7 commissioners in support and a 1 indifferent vote, and 1 just needed additional information. So there was a majority of support for this recommendation. And are there any commissioners who wish to discuss this item before moving forward? Hearing none.
Well, wait, before we move on from this one, I mean, one of the commissioners, someone on the survey indicated they needed additional information or they were unsure. Is the commissioner who in attendance today who made that response?
I am. This is Marilyn, and I got some additional information. It's just when I filled out the survey, I didn't know enough about it, so I did my homework and reached out. So I feel comfortable with it.
Okay, great. I just wanted to make sure. Thank you.
Thanks, Marilyn. And yeah, just so you know, Gabe, any that did say unsure, need additional information, I tried to provide some additional talking points during the slides today. So, but of course, if there are additional questions or comments from commissioners, please feel free. Moving on, recommendation number 4. This recommendation seeks to aid in workforce retention and provider wellness by establishing and funding a physician wellness program in Nevada to allow physicians and other providers to access an independent and confidential wellness program. It would recommend that the Department of Health and Human Services offer grant funding to an eligible 501c3 nonprofit, such as the Nevada Physician Wellness Coalition, to administer such a program statewide. The program must support physicians and other healthcare providers through evidence-based well-being initiatives. It must also provide a statewide physician and physician family resource line and online wellness resources and training. There was a comment from Commissioner Sexton, who wasn't able to attend today, so just thought I would share that. Her feedback was there would need to be strong firewalls in place to ensure that the organization selected did not have reporting requirements back to the state regarding any patient-specific data. Otherwise, providers may be nervous to use the resources for potential implications to their licensure. There was a majority of support for this recommendation. I'll now open it up for any questions or discussion from the commission members. Hearing none. Recommendation number 5 would recommend aligning licensure and facility training requirements to remove duplication, reduce administrative burdens, and expedite the onboarding process for healthcare providers. This recommendation seeks to remove any redundant requirements from provider onboarding process, while aligning the training from the facility standpoint and the licensure and continuing medical education requirements. The survey concluded that there was unanimous support for this. I'll now open it up for any questions or discussion. Thank you all. Next recommendation, number 6, would request licensure boards, hospitals, health systems, and the Nevada Division of Insurance to remove intrusive mental health questions from physician and other healthcare provider licensure and credentialing applications. This recommendation would support physician well-being and in turn support patient well-being and safety. By destigmatizing mental health care for physicians and other providers, it can create an environment that encourages voluntary self-disclosure and help-seeking behavior. According to the Dr. Lorna Breen Heroes Foundation, overly invasive mental health questions in licensing and credentialing applications prevent healthcare workers from seeking support and increase the risk of suicide. Such questioning tends to be broad or stigmatizing, such as asking about a patient's mental health care and treatment, which has no bearing on a healthcare worker's ability to provide care and violates the American with Disabilities Act. According to the survey, there was a majority of support from commission members, and I'll now open it up for any questions today.
So this is Commissioner Khan. I completely understand that you don't want to stigmatize someone just because they have mental health issues potentially, or they're just struggling a little bit and they need to seek help or seek guidance or counseling or something like that, and they should not just be dismissed because of that. However, I do think it is important that we have a good sense if someone is not capable at the time that they shouldn't be potentially practicing, they may need to take a break or be removed from a setting, medical setting, so that they can get the appropriate help that they need to get them back on. So I guess my only question on this was, how do you balance those two without being overly intrusive? So I guess my question was, what constitutes an intrusive mental health question that would deem someone feeling unable to go get the assistance that they need, but also flag for supervisors and whatever medical setting they're in to ensure that they are at that moment in time qualified or capable of performing their duties.
So this is Dr. Khan for the record. The challenge, as I hear and understand, has been whether if an applicant, for example, says, I have had a mental condition for which I've been treated, etc., and I'm rehabilitated. This could potentially leads the licensing board to request medical records on this person, which becomes an invasion into, like, the HIPAA, although the applicant has to authorize that. But to authorize that could potentially open up Pandora's box, whether his or her health information is public record and the board not public record, and so it opens up a Pandora's box. So that is one of the concerns about the so-called intrusive questions. On the other hand, if the applicant says, I had a condition, I remember from my days on the medical licensing board, and at that time, the questions were a lot more intrusive, but pertinent. Have you had any drug addiction or addiction problems? And the applicant had to say yes, if he or she had it. And could have been 10 years ago, 15 years ago, and then the board would start fishing all over to get all the information, even though the applicant has submitted, it was X number of years ago, I've been rehabilitated, I've been working in so-and-so place, and there are no complaints. The board could call them if there were any complaints about his functioning, but they would want the records.
Thank you, Dr. Khan. If I might, we have Dr. Gokul. He's the president of the Nevada Physician Wellness Coalition. If he can just speak to this and hopefully give additional information to Flo Khan, I would appreciate it.
Thank you, Joseph, for the opportunity. And thank you so much for that question. It's so important. We know that direct burnout is directly correlated to poor outcomes. And that's what we're all after here is improved outcomes for all of us, our family members and our community members in the state. Where these questions were initially derived from, I'm certain came from a good place. What we do know is that nationally surveyed, more than 40% of physicians admit that they will not be honest in answering these questions because of one, the fear of culture of silence, which is an unfortunate culture that has been developed in our training, in our practice, and we've seen the unfortunate outcomes of that. But two, the fear of the repercussions that come along with that. I'll share candidly very much a colleague of mine who in his training said yes to one of these questions because at the time he had sought out psychology support, a therapist, because he was going through a divorce. For 10 years thereafter, he had to report doctor's notes, psychology notes to the state board. You can imagine what that would do to a very qualified, skilled clinician and limit an individual's ability to provide that care. So again, I think what we're getting at here is wanting to certainly make sure that our physician workforce is well in order to provide better care to our patients, but we recognize that these questions are not leading to that. Our recommendation stems just from that, to remove this as a barrier and a hindrance, not just to take them away, but just certainly, and this ties into one of the before recommendations, but provide access and information to supposedly a state-based organization or a state-supported organization who provides mental health support that is autonomous and independent, and make sure that these individuals are aware that these resources exist.
Thank you. That appreciate. Any other questions from commissioners? Do you see any?
No, Dr. Khan, not seeing any hands raised.
Okay.
So I will go ahead and move on if there's no further questions, if that's all right, Dr. Khan.
Yeah, please.
Okay. Recommendation. The next recommendation would require each healthcare occupational licensure board to offer a temporary or provisional license to health professionals who meet certain criteria while documentation and background checks are pending. So some licensing boards are currently offering this in Nevada. It's my understanding that the Nevada State Board of Nursing currently issues a temporary license to all applicants who meet certain criteria while background checks and other documentation are being processed. Certain criteria that would make a person ineligible for a temporary license could include if they've been previously denied licensure by the board, if they have criminal history or disciplinary action by a state entity, if they are subject to a pending complaint or have had their license previously suspended or revoked by another state. There was a majority of commissioners in support of this recommendation according to the survey. I'll now open it up for any questions or discussion members might have. All right, hearing none, moving on. The next recommendation would ask the state of Nevada to support the establishment of a single state authority over all healthcare occupational licensing boards. It would request licensing boards report and be held accountable for certain metrics, for example, the duration of time from application to licensure. And a single authority over these licensing boards will help establish uniform standards, metric reporting, and reduce unnecessary duplication in requirements that can create barriers and delays for providers to enter the workforce. So I will note that currently NRS 232.8415, it does establish the Nevada Office of Boards and Commissions within the Department of Business and Industry. That was established last session through a bill, and that office, to my understanding, is still being developed. So to my understanding, it's still unclear how that office will hold or plans to hold any of these licensing boards accountable to certain metrics. And so this recommendation is just requesting that the state do so through that office or through another state authority. And so according to the survey, there was a majority of support for this recommendation, and I'll open it up for any discussion at this time.
Any comments, questions?
Okay, hearing none. The next recommendation would recommend Nevada develop public-private partnerships to fund healthcare workforce initiatives by leveraging resources from both sectors to maximize impact. This would include expanding federal, state, public, and private funding, investments into graduate medical education, residency, and fellowship programs. And as an example, the PPC received this earlier in the year, but as an example, SB 369 from last session, it did fail to pass, but that would have established tax credits for certain businesses who donate money to assist in establishing graduate medical education programs. So that could just be an example of how some of these public and private partnerships could assist with addressing the workforce needs. There was a majority of members in support of this recommendation. One was indifferent, and so I'll now open it up for any questions or comments commissioners might have. All right, hearing none. Recommendation 10 would recommend Nevada assign an appropriation of funding to the Division of Public and Behavioral Health within the Department of Health and Human Services to continue the Nurse Apprentice program over the next biennium. The Nevada Nurse Apprentice program has proven to be a successful and innovative earn while you learn model for Nevada to recruit and retain nursing students and address the nursing shortage. There was a majority of members in support of this recommendation. I'll now open it up for discussion. Hearing and seeing none. Thank you. The next recommendation this is a long one, so bear with me here. This recommendation would request the Governor's Office of Workforce Innovation and the Governor's Workforce Development Board prioritize workforce development in the healthcare industry. This would include prioritizing available funding, such as federal funding reserved for statewide workforce investment activities on healthcare workforce training, education initiatives, and apprenticeships to help increase the healthcare provider supply. Additionally, it would recommend that the Office of Workforce Innovation collaborate with the Department of Health and Human Services, Nevada area health education centers, and other representatives of the healthcare industry during the implementation of Assembly Bill 428 from last session to ensure that healthcare career pathways are developed to interest a person in entering or advancing in a healthcare occupation in high-need areas. This recommendation seeks to ensure statewide workforce development strategies and investments are utilized to support and grow the supply of healthcare personnel. I'll now open it up for questions. There was a majority of members in support of this recommendation. Okay, hearing and seeing none. Recommendation 12 would request Nevada create more opportunities for high school students to receive exposure to healthcare careers. So as an example, and there's several examples that could be categorized in this, but the state could offer students opportunities to obtain college credits while in high school if they took health-related classes, STEM classes, or received certain certifications, such as CPR certification, things like that. According to the survey, there was unanimous support from the commission on this recommendation. Are there any questions or comments?
This is not Khan for the record, just a comment. If this goes through or the legislature was to act on that, it is important for the medical school and the nursing schools and others, for their local applicants, to at least give the students some credit with their application for doing this in that particular healthcare sector. Right now, that does not necessarily happen. So if we are going to go this route, which is the right thing to do, then perhaps going a little further, that should be a consideration of some credits for doing this. I would like to hear from other commissioners. What do they think?
So, Dr. Khan, this is Marilyn. So can I ask this question? So are you just saying that maybe we add a line to this to say which will include potential credits? I think we have to let the legislature
Yes.
at least do something. I would support adding that line with potential credits, but I think you got to say potential because we don't want to limit it. So
Right, absolutely. I agree 100%.
So then maybe you just add the word to this. So when there's a motion to be made, Joseph, that says with potential credits, but not limited to, because then that gives them the ability to put some other stuff in there.
Yep, that's great.
I second that when it comes to vote.
Great, we can move on.
Thank you. I will note that edit. So just for clarification, we're going to request that the recommendation include that, Nevada medical schools, nursing schools, and other schools would give these students who participate in healthcare, classes or certifications receive credit for those when they apply to these Nevada-based healthcare related schools.
Marilyn's word, Joseph, was potential credit.
Potential credit. Thank you.
Yeah. Mhm.
We'll be sure to include that in the final recommendation, and I'm happy to work with Marilyn and Dr. Khan offline just to make sure I get the verbiage right in the final report.
Perfect.
Thank you. All right. If no other discussion on this recommendation, the next, sorry, Dr. Gokul, I think that was a accident. Okay, sorry, excuse me. Recommendation 13 would require Nevada establish a healthcare workforce development resource center. The state has many healthcare workforce initiatives and resources aimed at addressing workforce development. And as discussed by the commission, having a single resource for public and stakeholders to refer to would be beneficial. A great example is the healthcare workforce website being developed by the Division of Public and Behavioral Health, which, as was shown last meeting, exposes visitors to career opportunities, provides educational and training resources, and connects visitors to partners and other workforce stakeholders. So according to the survey, there was a majority of support for this recommendation, and I'll now open it up for any questions or comments.
Just one comment. This is Commissioner Conigan. I just feel like this recommendation is already acknowledged in some of the other recommendations that we've done. So is there a way to just combine some of these into like a singular thing? I mean, it's fine to say, yes, we're good with this, but there's already the office Go Win that's doing this. There's just the what was it, Nevada Health Education Centers that are doing that. I mean, there's so, like you said, there's so many options. I just feel like this is just redundant, but it's fine. And we're supportive of this.
This is Marilyn. Could I add? So my concern is I love this idea because there really is not a one-stop shop, but more importantly, there's a third of the legislature that is turning over. And I think sometimes you have to call things out. So maybe it's establish and maintain a healthcare workforce development resource center, because when you have a turnover in the legislature, like we're seeing often, unless they were a healthcare champion and they're still there, they have no idea what we have. So this is important and it is redundant, but maybe we add the word maintain so that they know it's something that we have to keep the funding going to. But if you don't call some of those things out, 1/3 of the legislature is not going to go looking for it.
Yeah, and I totally agree with that. My concern is that if we're creating 5 different things that are all doing the same thing, then we're just wasting resources. Why not just say, here's the one group, the singular source that we all get behind and that we want to support, and we're going to put funding towards that to do the 5 things that we want it to do, as opposed to creating 5 different organizations that aren't working together, unfortunately, and we're wasting limited resources on the development of all of these things. That's all.
No, so maybe it's maintain a healthcare workforce development resource center. Maybe it's that. You know what I mean? So that we already have something, but I mean, we know that cuts are potentially coming. So maybe we emphasize that importance.
And I think this is Joseph Filippi for the record, and I hear what you're saying, Flo, just in regards to all these other entities, are technically responsible for healthcare workforce development. And I think really this recommendation might need to be reworded rather than creating a center versus creating, I think it was mentioned by Commissioner Davis, like a hub. So however we want to frame this, but similar to what I think the presentation we received from DPBH, just how they were creating that workforce development website, whether that could live there or even on Office of Workforce Innovations website. I think what we were intending by this recommendation is to try to get, whether it's a website or a physical center or both, having all of the different resources and information in a single location, not only for legislators, but for, employees, employers to refer to, I think is what this recommendation is meant to be meant to do. So how we want to rephrase that, I'm happy to do so.
No, I think that's exactly what we wanted to get at. And so however it needs to be phrased, I think we should do that, because that presentation was wonderful the other day on how they're working to have the singular statewide site where, whether you're a provider today, a future provider, a student, whatever, it just had all of the resources available in one place that everyone could go, and and then they could go from there. So it's,
I will take that feedback, Commissioner Khan, and happy to work with you all offline and to just make sure that ultimately this meeting is meant to take this type of discussion and feedback to then develop the written report for you all to later review and approve. So I will take that feedback today for this recommendation and ensure that it's reframed a little bit in the final report, so we can have a final conversation during a future meeting, if that works.
Yeah, I think that's the proper way to do it. And so you've taken notes, Joseph, obviously to incorporate the language, and then we can all look at it and then go from there.
Thank you. Appreciate the discussion on that item. The next recommendation, as drafted, would require Nevada Medicaid to review prior authorization data and requirements to simplify and streamline the process for healthcare providers as applicable. It would recommend Nevada Medicaid establish a data dashboard to support transparency in the review of prior authorization data. And then following the establishment of such a data dashboard, Medicaid would review which prior authorization should and can be removed without undue risk of increasing fraud, waste, and abuse. And in addition, it would request Nevada Medicaid report to the legislature each biennium regarding the division's findings related to the prior authorization data, and also report on activities made to reduce the provider administrative burden. So just for everyone's knowledge, this recommendation seeks to streamline and simplify the prior authorization process for providers, and in doing so, the hope would be to remove unnecessary administrative hurdles and incentivize more providers to serve Medicaid patients. The language presented today is a result from consultation with PPC members and also the Nevada Medicaid leadership. According to the survey, there was a majority of you in support of this recommendation, and I'm happy to discuss any questions or comments that you have now.
So any commissioners have comments? Because before I give one, this is Dr. Khan.
Not seeing any. Dr. Khan, please go ahead.
First, the question, does this, because the Nevada Medicaid piece of this is a very small piece. The fee-for-service Medicaid is a very, very small piece. Bulk of the Medicaid population is in managed care organizations. Would this be applicable to them? Because I think, if I'm not mistaken, 80% or so, maybe more, somebody from the State Health Division could give us the correct number, but the large population is with the managed Medicaid.
So
Thanks, Doctor. Please go ahead, Stacy.
This is Stacy Weeks at Medicaid. Yes, we do. This is for both. So
okay,
we're streamlining across managed care and fee-for-service, so they all use the same forms.
Right, and the undue delay also, Stacy, there is undue delay in authorization process. So just getting an authorization is one thing, but the undue delays in getting authorization also frustrates the providers in their offices to get an MRI, CAT scan, and same with the hospitals. Patients sit in the hospitals for a nursing home bed or a rehab facility for days.
Well, that's a different issue. So that often is can sometimes be eligibility too. So This here would give us the funding and resources needed if we got legislation on this to support a different look at prior authorization. There's probably some we could require that are removed, that are unnecessary, especially if 90% of the time they're approved. We also would like to create a quality gold card or something like the private market does for providers who are quality providers who, do certain program integrity activities. I mean, we are dealing with a lot of fraud in our program too. So, we're trying to balance both needs here, but I think that this will improve the process. So it will align all the timelines and everything for providers in fee for service and managed care for all plans.
Yeah, that's very helpful, Stacy. Thanks.
All right, any other comments or questions from commission members before moving on? Not seeing any. Thank you. Thanks, Stacy. Recommendation 15 would request Nevada to conduct regular assessments of the effectiveness of existing state programs to determine where changes can be made to improve the capacity of the healthcare workforce. This recommendation seeks to ensure investments in state programs have high returns on their investment and provide the most value for the taxpayer dollar. And a majority of members did have support for this recommendation according to the survey. Are there any comments or questions from commission members before moving to the next? All right. Moving right along, next recommendation would request the state to prioritize healthcare workforce investments on producing more primary care providers, such as physicians, advanced practice registered nurses, physician assistants, and also other nurses. Consumers often perceive overall access to care based on the availability and affordability of primary care services. By increasing the number of primary care providers, Nevada patients will benefit from greater access to more affordable care. There was a majority of commissioners in support of this recommendation. I'll now open it up for any questions or comments. Hearing and seeing none. Next recommendation would seek to increase state funding to support Nevada Area Health Education Centers, also known as AHEC, to enhance healthcare workforce development pipeline efforts statewide. Nationally, AHECs are organizations dedicated to serving underserved and rural populations. In Nevada, we have 3 regional AHECs. There's High Sierra, Desert Meadows, and Frontier. AHECs have proven to be successful partners in Nevada and other states in implementing healthcare workforce development planning and other initiatives. And the Nevada AHECs provide education and training for students studying to become healthcare professionals. And they also engage with K-12 schools to interest more students in the field. Current funding constraints do hinder opportunities for service expansion and innovation to meet the needs of each regional AHEC. So this recommendation would request, an investment in AHECs, which can also be seen as an upstream investment that will assist in a recruitment of future healthcare providers. There was unanimous support from the commission according to the survey. And I just want to note that, this morning sent you additional letters of support for this recommendation that the commission has received through public comment. If there are any questions or comments from the commissioners at this time. Jalen, please go ahead.
Hi, Jalen Bihanan, for the record. Just a quick question. Is this related to recommendation 12? Or when we're looking at recommendation 12 about more opportunities for high school students, is that a different entity or would that be run through AHEC?
Great question, Commissioner. Joseph Filippi for the record. So this is a little separate. So this would be specifically supporting the Nevada AHECs. It would build upon that previous recommendation, as they do, provide a lot of opportunities for high school students to get into to engage them and provide them with information on different healthcare careers and assist them with going on that path. And so I think, definitely the recommendations are related, but separate, just because there's multiple, I think, various ways that high school students could be introduced to healthcare careers. AHECs definitely are a part of that, and they do a lot of this work, but I consider them separate.
Okay, thank you.
Any other questions or comments from commission members? Hearing and seeing none. Next recommendation is also related to Medicaid. It would recommend Nevada Medicaid pilot a virtual hospital at home program to increase access to care in rural and frontier areas of the state. Care models such as the emergency department in home and the hospital at home have provide in-home care for patients who qualify and would normally receive services in an emergency department or inpatient settings. The pilot program in Nevada would seek to increase access to emergency, outpatient, and inpatient care options in rural areas. It would also support the EMS system by reducing avoidable emergency department transports. It would decrease hospital overcrowding in urban settings and better allocate available healthcare workforce resources. The pilot program will include the combination of in-person clinicians, such as paramedics, with remote access to physicians and nurses to provide emergency level inpatient and primary care for patients who can safely be treated at home and in rural areas. Rather than removing patients from their own communities to access certain care, eligible patients would be able to opt in to receiving necessary care at their home. The pilot will allow an innovative opportunity for Nevada to share key learnings about safety, quality, and cost to inform future healthcare regulatory and payment policy. I'll now open it up for any questions or comments. There was a majority of members in support of this. We did receive one opposition, and one was requested additional information. So Marilyn, please go ahead.
And I was the opposition, just so you all know. But I guess for Stacy, for me, I would want to be sure that they were not billed as an ER visit. And I know I spoke to you about that, and I just want to put it out there that because it's not an emergency room, but I hope that we want them to get the care, but I hope that it doesn't become a money grab on how we bill. But I think you said there's ways to ensure that we're not paying high activation fees, high, the highest rate for that service.
Any other commissioners have comments? If not, this is Dr. Khan for the record. I have had some reservations, and I spoke about some of those at our last meeting. And what Commissioner Kirkpatrick brought up is also very important. To me, we started off with minute clinics in the pharmacies essentially long time ago, and I'm not sure how that gets billed. In this case, we are talking about in consultation with a nurse practitioner and or a clinician, the paramedics will provide services. So if they are actually consulting with a nurse practitioner or a quote unquote clinician, presumably a physician, how does that get billed? I think that's important to know as a physician visit, because he or she was consulted online. And in those cases where nobody was consulted and the paramedic came and said, you have, I think today you're developing a sore throat, I'll give you some antibiotics. And it turns out to be something else 2 days later, and no quote unquote clinician, which has to be defined, was consulted. What will be the metrics for these paramedics to consult at what level with a clinician in the interest of the quality of care for these patients? Stacey, you have any comments?
Yeah, I would just say that I understand all the concerns here, but we continue to have an access problem for so many people in our rural areas. We've got seniors not getting care and unable to get in. And I do think I hear the need to not be paying an ER visit, and I would agree with that. And I think obviously if the standards of care, which include supervision and physician oversight, are not followed, Medicaid can't pay for that anyways. So it would have to follow all standards of care in Nevada. And we would, if we were to develop this model, we would do it with public stakeholder input and, public workshop. But I really feel that we have to think outside the box and start thinking differently about healthcare. I would prefer that it's not an ER rate, because the ER rates are expensive, and to provide services in someone's home to meet them where they're at, especially in our rural areas, would be a huge win for a lot of our folks that we serve. So I appreciate all the feedback. I think it's definitely the things that we can address in the model that we would develop for Nevada.
So can I ask this then, Stacy? Can we at least put some of that in that, the pilot program shouldn't look at, have regulations that have like a financial, clinical, some of that in there so that it doesn't get lost in the translation? That I would feel more comfortable, and I know I bugged you about this, but I just, I don't want people to show up, give you a prescription and send you on your way, right? But
I
also,
don't either. Yeah.
right, I
Yeah,
want them to get quality care by quality folks, and I want them to not break the bank doing it.
Agreed. I don't need a bunch of standalone ERs in the home. I mean that from a kind place, but yeah, no, totally. I would appreciate that language actually. So, I mean, but that's up to the committee. Yeah.
Yep, thank you. And if I might, Chair, we have Lisa Tripp who gave the initial presentation to the PPC. Did you have a quick comment, Lisa?
I just wanted to thank you, everybody, for the comments. Very much appreciate them. I wanted to also let you know I've brought my colleague, Dr. Jacob Keeperman, who's an emergency physician and a practitioner of hospital at home, and also worked in ED at home. If Jake, would you just mind saying hello and perhaps quickly addressing some of the overarching concerns that we've just heard from the commission?
Yeah, thank you, Lisa, and thank you to the commission and to the chair. So as a Nevada resident, and I'm a Washoe County resident, I feel strongly that we can do this in a safe and financially responsible way. I'll tell you, the ED and home programs that we have done, every patient is seen by an emergency medicine board certified physician, by a high def, two-way, right, audiovisual, including both visual and audio, and when it said clinician in that was referring to the in-home, the person that is going in physically in the home, that the paramedic is the person who is physically there, holding the tablet, the phone up to the patient, administering the treatments, but the patient is evaluated and treatments are all prescribed by a emergency physician. So I want to be very clear that that is how the model has been developed and deployed elsewhere. Also, as a physician, and I'll tell you, you can get incredible care that is patient-centric, cost-effective, and frankly, sometimes safer than some of the care we provide in our healthcare facilities due to no fault of their own, right? And it is where I want my family members to get cared for. And in fact, I have had my father cared for in. So I do think that this is an important thing. I thank the board for considering this, commission for considering this, and hope that we can continue to help develop it with all of those safety features in place. And yes, we need to examine the finances, and that is why this is set up as a pilot. How can we best set this up for the citizens of Nevada, and in particular to really focus on serving those in the underserved areas and those in the more rural areas that don't have the ready access to the large medical centers.
So this is Marilyn. May I ask you a question? So across our rural areas, many of the EMTs are volunteers. So is this going to take away from those is it going to create another problem by now paying these EMT? I'm sure you got to pay these EMTs, right? I guess for me, I'm willing to move forward if there's some language in there, but I think that there's some harder questions that got to be asked, because you literally are relying on volunteer EMTs today across the rural areas, and even the rural areas within large counties. So
yeah, so
and I would hate to get rid of. It's hard enough to get volunteers, but now you're probably going to pay them like I would assume that you're going to pay them like a regular urban EMT. And so now I have a different problem, right? Who's going to respond to that car accident? Who's going to respond to all those things? So I'm willing to, for Stacy, because I trust Stacy, I'm willing to move forward, but I just think there's a bigger and harder discussion to be had about this later.
So I think and I think it's a great question. One of the really important things, and I think a a hallmark of a program that to be developed here is, frankly, we need to keep the critical access hospitals open, and we need to keep the services that they have and actually optimize the services that they have. So those are the places that we partner with to keep the local workforce and the local citizens doing it. And I love your comment, and I'm also an EMS medical director. And so I really love that you're talking about the rural areas, because one of my biggest challenges is training rural and the volunteer EMS personnel. This actually can provide funding to provide more support for those very people, right? And we will ensure that they are, one, responding to the time critical emergencies, and that when they can, right, we also are able to respond to the ED in home. So we would work with the state to develop it in the, again, the best way for those communities to fix it, because there is not a one size fits all, that the size that fits in a urban that has very well funded public or private EMS versus a rural volunteer base.
So any other questions from any other commissioners? I have a couple of comments after that.
Yeah, we do have a couple, Dr. Khan. Jillian, please go ahead.
Hi, Jillian Buchanan for the record. Like I said last time, I know this is not a completely new concept. You know, we know that Dignity Health is rolling out this program in Arizona. I don't have details, but I know that I just want to support the pilot, and I know you guys will look at other models to see if it's financially sustainable for the provider and the financial impact for the patient themselves. Like I say, this is not a completely new concept, and I trust that you guys are looking at ways it's been done throughout the country.
You have another commissioner?
We have a couple more. Yes, Dr. Khan. Flo, please go ahead.
Thank you, Commissioner Khan, for the record. I want to just kind of reiterate or echo Marilyn's comments about reimbursement, because all of this is funding. Everything that we talk about is, especially in the rural areas, is largely a funding issue, and being able to provide funding for more access to providers and everything. So, you know, you don't want to have a program that's going to, in essence, cost more money than what's already occurring within these areas, because that's just going to harm and limit access even further. It might provide some short-term benefit to individuals, hard to reach individuals, but overall it's going to depress and take money away from others in those regions. So I think that's one of the things that, as we're making this recommendation, even for a pilot, that it does have to be financially, there has to be a benefit to the community. And I think that goes along with what Stacy was saying as well. Like, look, you know, we want to make sure that whatever, you know, reimbursement rates that we're looking at or whatever are going to be at a lower cost than some of these higher cost services that you would provide in a hospital, I might add, because hospitals are very expensive. And so you want to get back to primary care, and you want to look at some of the reimbursement rates and telehealth and things that are a little less expensive in these areas. So whatever the recommendation going forward, I think needs to have some of that built in to ensure that we are protecting against higher cost as opposed to lower cost.
And can I respond to that quite quickly? In the New England Journal of Medicine, there was a publication in New England Journal Catalyst on this that showed a $1,500 per episode savings for providing this versus providing traditional ED care.
Thank you. We have Walter Davis. Please go ahead.
Yeah, hi, this is Commissioner Davis for the record. I just want to really say that, I mean, I think all of us are aware that provider resources are extremely scarce in rural areas. And as we look at these models and everything else, we're going to have to, you know, the answer is somewhere in the middle. But it could be either stipends or something else. I know employing those that are volunteers I think again we have to look at the the overall workforce model. We have prematuras that go out in other communities that help out, and they do different types of services in the community that the people that they trust. So I think again more exploration is going to have to be done for the cost part, because it definitely has to be sustainable over time. And I think but we can't be blinded by letting costs stop us from doing a pilot program either. So any types of support I could give, or any other as a FQAC can give to pilot this, be more than happy to do so.
Thank you, Commissioner Davis. Stacy, did you want to say something?
Yeah, real quick. I appreciate that, Walter. I think that's absolutely right. And one I thought I had here while we were doing this, because, if this passes, we get funding and all of those things for it, you could put language in here that Medicaid would bring back to this group models and ideas around the benefit structure, and you guys could provide feedback on that, and we could have more of a community discussion. We'd still do a public workshop, but we could be more engaging in the development of this, and in a way that I think can make maybe folks here feel more comfortable, and also feel like that they can stay engaged in the process. So happy to do that if we want to add that language, that's something Medicaid would completely be happy to do.
Thanks, Stacy, and really appreciate all the discussion and feedback today, and definitely took a lot of notes. So we'll be revising this recommendation and bring it before we finally submit it near the end of the year. Go ahead, Dr. Khan. Sorry.
I'm sorry. So we need to also keep in mind the qualifications of the people who are going to be doing this. Just a regular paramedic, would he or she require some additional training to do this? In some cases, critical home care. There are people currently that go home who are on chronic ventilators for longer time. And there are some trained people on home health services that would send a nurse to keep an eye on that. So is there a program to give these paramedics some special training? Because this is a different setup than just picking up a patient from the street and getting in the ambulance and taking care of them for a cardiac arrest or intravenous fluids.
Thank you,
Yes,
Dr. Khan. Go ahead, please. Dr.
Sorry, I never said for the record, but Jacob Keeperman, Keeperman, my name. But yes, there are. So there are community paramedicine, sometimes it's called mobile integrated healthcare, that are extra training programs. So they typically require people to have a few years of paramedic experience prior to entering these programs. And the programs vary anywhere from 3 months to a year long in various parts of the country that provide this. And then there is a certification. There are a few national certifications they can get in this. And so, yes, highly do insist, in fact, that those that are providing care, certainly the programs that I have been overseeing and been involved in, do have that higher training. We also have more extensive quality assurance, quality improvement programs, and are constantly overseeing and providing feedback.
So do you have a manual of all these quality metrics, et cetera, documented somewhere, that these are the quality metrics that will be followed, whether it is the training requirement, et cetera, of the paramedics, all that stuff?
So whenever a program starts, we develop that for that program, depending on what exactly that particular patient population or need is. So yes, that is all part of in the implementation stage of the program, is setting that with essentially service level agreements to each individual provider who may be going in, or their organization, of what those qualifications, safety metrics, et cetera, will be.
All right, thank you.
Yes.
So, Dr. Khan, I hate to muddy these waters a little bit more, but Stacy, we ask our managed care folks that get a lot of the Medicaid dollars to do a little bit extra for the community. And as I'm hearing you talking about this extra training that these volunteers got to have in these rural communities where they're already barely making it to begin with. But in Clark County, we put $5 million towards a paramedic school and I had 10 people in the rules and I have 10 people later. I would hope that you could have a conversation with the providers that want to do this to kind of pay for that paramedic stuff or pay for a stipend, because one, it'll be beneficial for them to have all that extra stuff, but at the same time, I'm paying people, $50,000 a month in my rural communities as a pilot program to stay at home and get through school in a quicker fashion, so that they could get back on the streets, right? So I hope that could be part of some of the conversation, because I would, people know me that I just don't want to see a bunch of people come in, make their money and split, right? If you're going to come in and you're going to be in my rural communities, really be in my rural communities. So just food for thought,
Nope.
but I hope you bring
Yep.
it back to us.
I very much appreciate that and think that's right, but I would just say, I can't speak to the procurement, which we should be dropping hopefully any day now. The MCO one, and I think we talked about it publicly, the need for the rural areas to get some of those community reinvestment dollars. So I feel like I can't speak to that. And I definitely think there's some opportunity there to support this type of infrastructure, really is what you're talking about. So yeah, totally agree, Marilyn. Thank you.
Thank you. Any other comments? We need to move on.
Hearing and seeing none.
Okay, you can proceed to the next recommendation, Joseph, please.
Thank you all. So the next recommendation would recommend each healthcare occupational licensing board, including the Board of Medical Examiners and the Board of Osteopathic Medicine, provide licensure reciprocity for healthcare providers seeking licensure in this state. It would also require licensing boards to provide for a temporary or provisional license, allowing a provider to practice while fulfilling requirements needed to qualify for endorsement in the state, or while awaiting verification of documentation supporting such an endorsement. It would require licensing boards to issue a temporary or provisional license based on an affidavit from the applicant that the information provided on the application is true and that the verifying documentation has been requested. This process exists for nurses and military spouses already and could be expanded more broadly to streamline the licensure process and avoid unnecessary delays that prevent providers from practicing in Nevada. According to the survey, there was unanimous support for this recommendation. Now open it up for any questions or comments. Hearing and seeing none, thank you. The next recommendation would recommend establishing an agency and/or a task force to lead statewide healthcare workforce efforts, conduct a comprehensive needs assessment, and be responsible for convening state leaders and other healthcare industry stakeholders to develop and maintain a healthcare workforce strategic plan. Several states have taken steps to more holistically assess their healthcare workforce needs. For example, as part of its annual budget, Virginia directed the Virginia Healthcare Workforce Development Authority to conduct a study of primary care, behavioral health, and nursing healthcare workforce issues. Also in Vermont, legislation was passed which created an advisory group to develop and maintain a current healthcare workforce development plan. Other states have also contracted with vendors to help conduct comprehensive needs assessment and also coordinate necessary stakeholders, etc. According to the survey, there was 3 commissioners in support, 6 were indifferent about this recommendation, and I'll now open it up for any discussion or questions there might be. Okay, hearing and seeing none. The next recommendation seeks to create a funding source to provide incentives for healthcare workers. Examples could include expanding loan repayment programs in the state or creating a housing assistance program for providers. Investing in these retention incentive programs will encourage healthcare professionals to practice in Nevada. There were a majority of you in support of this recommendation. Any questions or comments before moving forward? We're nearing the end. Thank you all for your patience. Next recommendation would seek to fund and sustainably support a Nevada Nurse Workforce Center to serve as a hub to advance nursing education, practice, leadership, workforce development, and policy. Nationally, state nursing workforce centers use an evidence-based strategy for nursing workforce planning. They utilize data-driven insights and expert consultation at the community, regional, and state levels to foster meaningful discussions about the real challenges facing the nursing workforce and practical solutions to address them. Prior to today's meeting, the commission received letters of support regarding this proposal from the Nevada Action Coalition, the UNLV School of Nursing, the UNR Orvis School of Nursing, and the Nevada Rural Hospital Partners. According to the survey, 4 were in support, 5 were indifferent. I'll now open it up for any discussions or questions. Hearing and seeing none. The next final recommendation before moving on to the letters of support. This recommendation requests Nevada support direct care workers by strengthening career pipelines, expanding training and educational opportunities throughout the state, and increasing wages and benefits for the existing workforce. Direct care workers are categorized as nursing assistants, home health aides, and personal care aides, and they provide essential services in a variety of settings, including home and community-based settings. With an increase in demand paired with high turnover rates, strengthening this workforce will ensure Nevadans have access to the assistance they need for daily tasks. By strengthening the direct care workforce for more job seekers, by strengthening this workforce, more job seekers will consider these jobs as career paths, which would help with recruitment, and more will consider to stay in the field, which helps with retention. There was 5 in support, 2 were needed additional information, and 2 were indifferent. I'll now open it up for the commissioners to discuss or ask any questions on this recommendation. Hearing and seeing none, there is a few letters of support that is up for the commission to discuss on either sending or not. So the first letter of support would support the prompt payment law, which was developed as BDR 57367 by the Nevada Commission on Minority Affairs. This measure is aimed to establish a reliable and prompt reimbursement system for healthcare providers, and it would foster a conducive environment for the growth of medical practices and improve healthcare access for Nevada residents, with a specific focus on reducing disparities in minority communities. According to the survey, a majority of you are in support of sending a letter on this BDR. I'll now open it up for any questions or comments today. Okay. Second letter of support would be from the commission to support BDR 352, which was developed by the Joint Interim Standing Committee on Health and Human Services, and it would establish the Social Work Apprentice Program. The program is modeled from the successful Nurse Apprentice Program and will create a long-term social work development pipeline that will aid the state in recruiting and retaining social work professionals. Majority of you are in support of this letter. And any questions or comments before moving on? Okay. Next letter of support, topic 3, the commission would support BDR 354, which was also developed by the Joint Interim Standing Committee on Health and Human Services, and it requires all entities that license or certify healthcare professions in the state to develop a process to expedite the license or certification process by giving priority review status to applications from applicants who intend to serve in historically underserved communities. And it will hopefully increase the access to care and prioritize licensure and onboarding for providers who wish to serve in rural and underserved areas. There was unanimous support for this letter of support. Are there any questions or comments? Hearing and seeing none. Topic number 4, the commission could support a recommendation that was submitted by the Nevada Silver-Haired Legislative Forum. It was submitted to the Nevada System of Higher Education and the Sanford Center for Aging at the University of Nevada, Reno School of Medicine. And it's asking them to include courses in basic geriatric care for all healthcare training programs in the state. This letter of support stems from a Commission on Aging meeting where I was asked to provide an update to the PPC during that meeting, and they shared data relating to the lack of geriatricians in Nevada. According to that data, there are 9 geriatricians per 100,000 residents who are age 65 or older, which puts Nevada at 33rd in the rank of states throughout the nation. So this recommendation would help address the growing deficit in geriatricians. who provide care to older adults and also support clinicians, especially primary care clinicians, who will be providing the majority of care to older adults. There was a majority of support for drafting this letter, and I'll now open it up for any questions or comments. Hearing and seeing none. Final letter of support would be from the Commission to support BDR 456, which is developed by the Legislative Committee on Senior Citizens, Veterans, and Adults with Special Needs. The BDR would require the Department of Health and Human Services, University of Nevada, Reno, and UNLV Schools of Medicine to establish a system of care for the diagnosis and care of Nevadans with dementia, and it would be known as the Nevada Memory Network. The network will be expanding capacity by hiring or contracting with neurologists, neuropsychologists, and geriatricians to perform the duties prescribed in the request to diagnose dementia in patients referred by primary care providers. There was a majority of you in support of this letter, and happy to open it up for any questions or comments. Right. That concludes our work session items.
This is a great job. I mean, you went through 23 of them, and everybody had an opportunity to chime in. So that was very, very helpful. Thank you. Any other
thank you.
Before we go to the next item? Do you see anybody, Joseph?
No commissioners are wishing to speak, doesn't look like.
Oh, okay, great. So we are on item number 6, which is public comment.
Thank you, Dr. Khan. So now open it up for any members of the public who wish to give any comments today. Again, if you're joining by phone, please press *5. If you're joining by Teams today, just press the raised hand icon at the top of your screen. Dr. Khan, it looks like we do have a couple comments in the queue. Dr. Gokul, please feel free to go ahead. You have 3 minutes.
Thank you so much. I just wanted to reflect back on Commissioner Flocan's comment before to clarify my statement. When we regarded about the destigmatization, it was asking about invasive questions on individuals' history of exams. In our proposal, what you'll see is there is still, for safety and of course quality outcomes, questions regarding current active conditions that may impact an individual's inability to practice. So I just wanted to clarify that.
Thank you. You have somebody else?
Thank you, Dr. Gokul. Yes, we have a caller with the last 4 digits of 1315. You can go ahead and unmute yourself. I believe you press *9 to unmute. Still look like we're muted. Okay, we'll hopefully we can hear from you. If not, feel free to send any comments, written comment via email or other means. Chair Khan, we do have one more request. Jacqueline, please feel free to state your name and go ahead.
Yes, thank you so much. I'm Jacqueline Nguyen, Nguyen, with the Nevada State Medical Association. And I want to take this opportunity to sincerely thank the Patient Protection Commission and applaud your work not only with your BDRs, but with your recommendations and your letters of support. We are in strong support of some of these initiatives and offer NSMA and our physician and physician assistant members to be collaborative partners to you and any of the groups working to increase access to quality healthcare in Nevada for our citizens. Thank you so much.
Thank you.
All right, Chair Khan, I'm not seeing any additional hands raised. Oh, excuse me. Right as I said that, we have a couple more requests. Deborah Collins, please state your name. Go right ahead. You're muted, Deborah. Deborah Collins, are you wishing to make public comment? All right, might be having technical difficulties. Chair Khan, I'm not seeing any other requests. Deborah, feel free to send in any comments you have via email.
Thank you very much. And I really want to thank all our commissioners and Joseph, you also in particular. I think our meetings have been running very nicely and a lot of input is given in a very efficient manner. I thank you all because you come and volunteer time for these major recommendations to go to the legislature. I hope they will be able to approve a lot of our hard work done to make it a little easier for them to make decisions. We'll call for adjournment now, and thank you, everybody, till the next meeting.
Walter Davis, did you have something to say?
Yes, I'm sorry. I just for clarification, as we were going through the recommendations, I thought we had agreed to vote on them all at one time. And am I mistaken?
You might be accurate there, Walter. This is Joseph Filippi for the record. I guess if it's okay with the chair, we could take a step back, go back to agenda item 5, and I guess take a vote on approving the recommendations as discussed today. And of course, taking back any feedback from the commission to provide the final draft of the recommendations within the report for your consideration later this year.
So I would request for a motion to approve all the recommendations. Is there a motion from someone?
Chairman, this is Wendy Simmons. I so move.
Is there a second?
And just for the record, the motion is to approve the recommendations with incorporating the discussions as noted during the discussions that you had on each item. Is that correct?
That is correct.
Okay, thank you.
This is Andrea Peterson. I can second that.
Great. Any opposed? None. The motion carries.
Thank you. Thank you all. Yeah.
So if nothing else is on the agenda, we stand adjourned. Thank you very much again.
Yep. Appreciate everyone's time this morning. Thank you.